Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor of the series here at Elsevier, and for our 9th podcast, we'll focus on the October 2023 issue on updates in abdominal core health. Over the last 2 decades, there has been substantial growth in technique, technology, and appreciation of the abdominal core. This issue of 16 articles is a complete review from basic physiology and function to specific advances in management. Here to discuss 4 articles from the issue will be a consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the Abdominal Core Health issue, Dr. David Kripata, associate professor of surgery at the Cleveland Clinic Foundation in Cleveland, Ohio. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John, very much for the introduction as always. And Dr. Kripata, really nice to have you with us today. And thanks to you and all your colleagues for putting this issue together for us. It's fantastic and gives us a ton of material to go over, particularly as regards general surgeons. This is always something near and dear to their heart, even if it's just slightly below it. There are 4 chapters we're going to cover out of this particular issue. Certainly, you could pick any group of them to go through, but we picked 4 that I think is going to lead us through a discussion about what we'd like to cover today. The first one is basically on the abdominal core health and what is it by Dr. Benjamin Palouse. For as long as I can remember, I've been trying to work with my own learning and with teaching other surgeons that you can't think of the hernia defect as a whole in nothing. It's got to be a defect in some system, and you've got to understand the pressures on the system to pick your repairs. And I don't think anybody really has written as succinctly as Dr. Palouse has in this about the abdominal core and what it is and the pressures that it involves. So, in the description that we really create a box of interrelated elements and pressures are involved. So just give us your overview of how you like to explain or how you would want people to think about the interrelated elements of the abdominal core.
Thanks for having me. I appreciate the invitation. One of the things that I think with this issue really jumps off the plate, as you alluded to, is the concept of abdominal core health. And this article by Ben Paulus, who's a former president of the American Hernia Society, is actually, he was the first person to really start pushing this concept forward. And what I've learned from him and what is abdominal core health to me is really a mind shift in how we think about hernia defects, in terms of, is this really just a hole, as you kind of mentioned? And if you just take a step back and you say, let's go back 25 years and think about fixing a hernia. Well, the main reason why we were fixing a hernia is that we wanted to prevent somebody from getting a bowel incarceration and requiring an emergency. And so when you think about, well, what your objective is, it's just to get rid of the hole and prevent that from occurring for that patient. Fast forward to the way I think we should think about it now, and the way Ben alluded to in his article is that it's a lot more than just a hole, and there's functional consequences to what that defect actually means. And I'll give you an example. Is like we actually did a study on these patients who had midline defects in their linea alba and put them through something called a biodex, which is when you measure their abdominal core strength in them doing a crunch or a sit-up. We did it before they had surgery. Then we recreated the linea alba, fixed their hernia, and then ran them through it again. And they not only had an improvement in their strength when you restore the linea alba, but also in their quality of life. So really the concept of abdominal core health comes to changing your focus to physiology rather than just a pure mechanical repair of a defect, and the physiologic consequences for that patient, which is their quality of life. So it really changes the concept to function and quality of life.
Well, that brings us to an interesting point and something else that was in Ben's article. We've got good ways of testing like cardiac output and ejection fraction, and we've got pretty good ways of testing other forms of strength. The abdominal core because of the relationship of the organs, it doesn't lend itself as well to a single number testing thing. So there's a number testing constructs, that Ben put in his article, some of them isometric, some of them isokinetic. But what's your preferred method for sort of finding out how well somebody's abdominal core is working and predicting whether or not further manipulation is going to be a benefit to them?
Yeah, I think you can first and foremost see the challenges in trying to run somebody through isometric and isokinetic testing every time they get a hernia repair. So while that might be a gold standard to really examine what the impact is of fixing somebody's defect, what we currently use is a surrogate for that, which is called Hercules, which is a quality of life assessment tool. It is specific to a disease process or hernia repairs. So we actually created a 16-question Hercules quality of life tool and looked at it in relationship to core function through those isometric testing, and identified that it did correlate well. And so that is our first line for using in our research to compare preoperative and postoperative quality of life and function. Is a simple questionnaire. Now that questionnaire has undergone some changes. It's down to 12 questions, and we're further trying to define its best use. But right now, that is what I think is the best way to get everybody to kind of get a measure on them.
Yeah, and I think, historically, we haven't paid good attention to just the mechanics. The argument was always, what's the risk of the operation now versus what's the risk of having to do something emergently vis-a-vis a problem with another organ set, incarceration or strangulation or something of that nature. And I think now that you're getting into a more generalized, your core actually does some work for you. And it's not hard to figure out. It's, it's almost a black swan concept. After you hear it, you can't believe you didn't think it all along. But, we all know people that go to take a deep breath and everything pushes out through the midline, and they try to exhale and nothing goes anywhere because nothing pushes back. And the other issues that come up with it, and certainly in the colorectal world and people who have other issues generating intra-abdominal pressure, it's kind of a no-brainer. Do you have any specific cutoffs or measurements that you look at and you say a repair isn't going to gain you much, or repair is going to gain you a lot, but you're not up to it? I mean, how do you use the tool practically?
Yeah, we have actually never looked at it to answer that question. So I don't think we don't have a quality of life metric in that sense to say we anticipate if your quality of life is this, that you're going to get to this level if we repair you. Because what we've actually seen also is people with loss of domain, if you do a bridge defect, you're not restoring the linea alba. So from a functional standpoint, you're not getting the same gain that you're, physiologically looking for with a abdominal wall reconstruction. But if you ask those people about their quality of life with the Hercules tool afterwards, you do actually get an improvement in their quality of life. They still notice a bulge, but they get a functional improvement in their quality of life if you ask them through the questionnaire. So that's why I don't know that we can use it to say you should get a surgery or not get a surgery. I think when it comes to deciding on whether or not you should restore the linea alba as part of your operation, then we just use defect size. So you're not going to get the same functional gain by closing a 1 centimeter umbilical hernia as you're going to get with closing a 10 centimeter wide defect, because the impact on the muscle itself is so small with that 1 centimeter defect. You're probably not having a tremendous functional impact.
Well, that brings up another set of interesting points, one of which I was going to talk about now, but I think we might put it off a little bit later. But I would like to get back when we kind of wrap things up on post-repair physical therapy, which Ben talked about. It's a great idea. I think almost nobody does it. But I think when we get back to, we're talking about post-operative issues, particularly pain, maybe let's wrap that into there. But I think the bridge repair, so one of the other articles we selected was mesh position by Nir Messer and Mike Rosen. And in that, Mike and his partner lay out the four basic modes of mesh placement: onlay, inlay, sublay, and underlay. And it's a great article, I think, in terms of pointing out the trade-offs for each. But bridge repairs are what I suspect we would refer to as inlay as well, things that cross the defect and don't secure the middle. So give me your take on sort of the pros and cons. I mean, I realize it's an entire article's worth, but just your general rundown on each of these. And the next question, just so I had to tee it up, is who's best positioned to do the various versions of this?
So onlay, I think, probably has more of a role than people realize, but it really comes down to patient selection. So in terms of putting the mesh on top of the muscle, if somebody has a hostile abdomen, that's obviously a great place for it. But even when people are, if they're generally healthy, non-diabetics, non-obese, and their risk of a wound complication is low, doing something for a smaller defect as an onlay is certainly a reasonable approach. One of the downsides to that is that depending on how you fixate the mesh, you may end up with a drain in the abdominal wall for a longer period of time to prevent seromas from forming on top of it. So there is a trade-off there.
So let's just take one brief second. What are your thoughts on drains and bioprosthetic material being in close proximity?
Yeah, so we've actually looked at this before. I don't see an issue with it. I drain just about all my meshes for larger defects. If it's in the sublay, I will typically put it on a drain as well to prevent seroma formation. The presence of a drain alone, we've demonstrated, does not have an association with an increased mesh-related complications such as a mesh infection. So I am more of an advocate of draining. I understand there's people who don't, and you see it a lot more with some robotic surgery and placing the mesh in the sublay position, where historically for open cases, I think it was pretty routine to put drains in those locations, but the robotic surgeons are more routinely not putting drains in. So I think there's certainly an area for additional investigation, but my current position is that I have no issue putting a drain next to a piece of a mesh. And I don't prolong antibiotic use if I do either.
As it turns out, you and I are on the same page, so we agree. Whether we're right or not remains to be seen. There's always a lot of opinions in surgery, and occasionally there's data for them. There's been a divide. I know when I grew up, when I was growing up, I got a ways to go still, but it was either a drain or a mesh, but never both. They never had any good data. It's just what they did. And had no reason to tell them they were wrong, had no reason to tell them they were right. But I'm glad to hear you guys have followed that up. All right. So the onlays. So what do you think about the role for inlays and not bringing native tissue back together?
I think at this point, one of the things that's been clearly defined in hernia surgery is that there really isn't much of a role for definitive repair with an inlay. It really is much more of a bailout type procedure. And you have a difficult abdominal wall after a difficult abdomen, and you just need to help maintain the contents of the abdominal cavity and give it some structure that's going to be temporary at best, and that's the role. So, an example of that might be you end up taking down a fistula and somebody has a large abdominal wall defect that can't be closed at the time, and you're going to stage their repair and try to give them a formal reconstruction in the future. That's probably a role for either a Vicryl mesh or a biologic mesh, just to try and help maintain some structure as you get them through their fistula repair.
In my other job, when I was working for the Army in the downrange, we certainly had people come in missing big chunks of their front. I'd say probably in my career, I've used it more for that than anything else. If you take out the war surgery side of it, as you say, we used a lot of Vicryl, earlier in my career. I can't seem to get my hands on Vicryl mesh these days, not because I don't make it, just because my institution won't buy it. So I'm usually left with something more expensive in these situations, like, some sort of bioprosthetic material. At least for me, I think bioprosthetic material in an inlay is an interim repair. You're buying time to the next repair. Do you feel the same way?
Oh, 100%. Been studied, and it's been looked at that 100% of the time, if you use a biologic mesh in an inlay position, bridging that sort of fashion, it will recur. You'll get a bulge again. You'll get a defect that you have to address in the future. Doesn't mean that it shouldn't be done, but understanding the limitations of that repair and what your goals are for that patient in that setting. And I think that kind of goes back to a lot of, I think what we're going to talk about later, but also with abdominal core health, is that, hernia surgery isn't about, I have the best repair, and this is just the one thing that gets done for everybody. It's about tailoring the approach to make it most appropriate for the patient and kind of developing your skill set as a surgeon to be able to offer that to them.
I see that's the battle we've been fighting And this is my 40th year doing this, and trying to get people away from the concept that there's a single best practice to where you have to have a lot of different tricks and tools and tailor them to the problem you're dealing with. In every discipline I've worked in, this has been something we've wrestled with people about. It's the infamous they. Usually somebody's saving money by buying this or not buying that or something. But you just got to have a lot of tricks. And I think even when it comes to open, videoscopic, robotic, what have you, you still have to have a series of tricks because there's no one size fits all there either. That's a hard nut to crack. And you guys are probably doing a better job than anybody with it. So good for you.
I think it's okay to have a value proposition in hernia surgery. And I think it's okay to recognize that we've introduced a lot of technology as well as a lot of prosthetic materials. And just because something is the latest that's out doesn't always mean that it's going to provide the most value to the patient or even the healthcare system. There should be some responsibility on us to consider that. And so when you do that, I think it forces you to examine, is an IPOM going to be better than doing abdominal reconstruction for a defect that's only 4 centimeters? And so I think that's where we need to really reflect on what the quality of life impact is for the patient, as well as the value to the system.
Let's talk a little bit about sublays and then underlays in particular. So give me your thoughts on sublays, because at least according to Mike's paper, he thinks those are the most technically demanding and big reward, big risk if you don't get it right.
I agree with Mike in that statement. Sublay, and we'll define that as anything that's put in the retrorectus space or in the preperitoneal space. So maintaining outside of the abdominal cavity, but below the muscular layer. Now, over time, one of the things that's been recognized is that probably one of the best ways to do that, but still technically challenging ways to do it, is to do a transverse abdominis release or posterior component separation. And that is, I think, what Mike alludes to when he's talking about the risk and the technical requirements to be able to do that. I think placing a pure Reeve Stopa type repair where you're not going beyond the linea semilunaris has a little bit less technical challenge to it, but still certainly different than doing like an IPOM. So in terms of sublay position and its role, I think that ultimately, sublay is a very beneficial position, because if you go back to the value question, it allows you to put the cheapest piece of mesh in a position where you provide the lowest risk to the patient when it comes to prosthetic risk to the patient. What Mike alludes to is the risk of what you have to do to make that happen. And if you don't have a good knowledge of the abdominal wall anatomy, understanding of the linea semilunaris, the neurovascular bundles in the retrorectus space, and what is required, and if you make a defect in the linea semilunaris, which is something that we're seeing more and more commonly, is you may end up leaving that patient in a worse position than they started with. We've seen people where they've had linea semilunaris defects on both sides because of surgical misadventure through the linea semilunaris, and then they have 2 defects, and it's totally destroyed what we were trying to achieve, which is a functional abdominal wall. And it's made them less functional than they started. So in that sense, I think, it's high risk, but also high reward.
And as we discussed a little bit before the podcast recording began, there was a fairly sizable article in New York Times, which 2 of our contributors, Mike Rosen and Ajita Prabhu, were interviewed about and commented. And if I remember right, it's been a while since I read it, but I think they were described as like Mickey Mouse ear hernias or something like that. But a lot of people are digging in, and I mean, what you read in the lay press is always up for grabs. At least some of the people were sort of alleging that it had these problems and then shipped them off to your group or people like you, that their sum total of gaining knowledge to do these procedures was YouTube or some sort of unofficial training paradigm, which you can learn a lot on YouTube, but I don't think that's one of them. At least that's not the way I'd advise people to learn it. You guys are in a position unlike anyone else in that you do a lot of primary repairs, but you also have to pick up a lot of pieces of other attempts that didn't work out ideally. I guess, what advice do you give people out there that are trying to work that trick into their armamentarium? Is it like, if you don't get some formal training and really get comfortable with it, just move it along, or have you got something else to guide them?
Yeah, I think so. That the New York Times article is certainly a very interesting one. And I think that there's 2 key points to that. I think the YouTube comments, as I think a lot of people focus on, because that's probably the most sensational finding in the article. But I think really the heart of the article, in my opinion, is getting back to what is the most appropriate operation for the patient. And are we actually doing that? And to me, that's where the article probably has the most value for us as surgeons.
I mean, articles like that, to me, they're not necessarily useful in the scientific sense, but they do give me a sense of what the communities we serve are getting for a diet of their information. And thinking about, if somebody were to come into the office and ask me about it, how would I respond? Reassure them or tell them what to do. The thing is I think a lot of people think that every hernia operation is somehow something that is simple and they can do. I think after you get partway into your career, you disabuse yourself of that notion. And then you get into some of these are so miserable, I don't think I ever want to do them. And then you come out the other side and you learn how to do it and you get back into, you just got to have the appropriate amount of respect because any of these can go badly and any of these can go well. And you've got to match you and your team's skill set to the needs of the patient and their physiology and anatomy on a given day and make sure you don't confuse any of your assessments of the above. And I guess I'm guilty of having brought up the YouTube part, but I do think that it's hard for people to get training, given our training system.
To address that sort of portion of it, if I was going to give some advice to surgeons to venture into abdominal wall reconstruction and how to do that most appropriately, obviously, I think we agree YouTube is, if you have no experience with the abdominal wall and understanding the anatomy, that is not the place to start. If you are very facile in abdominal wall hernia surgery and you're getting a minor improvement in the technique, you're just trying to see how somebody else does it to pick up some minor tips and tricks, I think watching well-trained surgeons and their videos can be helpful. I think people who want the opportunity to advance their practice beyond what they currently do and are not currently in training, there's a few avenues. Number one is get involved with some of the societies and their hernia training programs. So American Hernia Society, SAGES has some hernia courses. And that's just, to me, the introduction of the concepts. We actually offer a program where people can come and do a sort of couple-day fellowship where they can come to our institution and we'll get them a medical license in the state of Ohio. And they can actually scrub into cases. And so they're getting hands-on just as if they were doing training back in residency and getting hands-on experience. And I think between, proctors and getting hands-on experience, that is how you should most safely try and introduce some of these concepts. Learning to do something through a new technology and then applying that technology to what you see everybody else doing in a YouTube video is when things, I think, can become dangerous.
Yeah, I mean, a long time ago when I was a program director, I very unsuccessfully tried to convince big surgery, when I was part of that world, that we should have some concept of modular training, not just for people who are going through their initial training, but so that people could take time out, whether it's 2 weeks, 2 months, 3 months, 6 months, somewhere along their career and go back and really develop some mastery of something to bring it back to wherever they came from. Because of economics and a whole bunch of other reasons, that has never flown. I think we'll get there one day, but this is a good example. I bet you if somebody were to come and work with you guys for, a couple of days is great, but I bet you if they were there for 2 or 3 months and worked with you guys every day, they'd see enough variations on the theme and have enough exposure that their game, if they were to go away, would be substantially improved. And their ability to realize what they should pass on would be substantially improved.
Your last point is probably the most key in all of that is patient selection when you're in this growth phase of your own surgical skill set. It is okay if you're just learning to do the easy ones and to pass on the hard ones until you develop that skill set completely, again, using the avenues we've kind of described.
Yeah, when I did a lot of pancreatic work, I would tell people it's a lot like walking on a ledge. It's all good up until the last step. You got to know when to stop. You're in free fall, and it's not like the Wile E. Coyote cartoons, But before we leave Mike's chapter, he goes a bit into the, surgical site occurrences, general thoughts on how we recognize, prevent, or deal with the various things we encounter. Bleeding seromas, local failures?
There's probably 2 points I would bring up. The first is just being meticulous. Prehabilitation is probably an important concept in terms of making sure that the patient you're taking to the operating room is well suited to be there as you, and make sure that you're controlling diabetes, discussing weight loss and smoking cessation beforehand. And then the second has to do with your own technique, and be meticulous about that. The one thing to recognize, you kind of talked about this earlier, is that there is no perfect operation that has zero complications. That is a normal part of being a surgeon. It's part of the healthcare world. That's when you're taking care of people, nothing is perfect. And we all have to recognize that, and we accept that. I think if you accept that and you translate that into your patient selection component, which is doing the right operation for the right patient, then you start recognizing that smaller defects are probably better treated with a lap or robotic IPOM, as opposed to an open large retrorectus sublate repair. You can minimize some of your SSOs and SSIs by your decision making on what you offer the patient up front. So I think that's part of it as well.
I'd like to move on a little bit to the article from Ajita Prabhu on devices and hernia surgery. And I had the great privilege of working with Ajita many years ago in Maine before she went to North Carolina and then to your shop. I understand she's running the program up there now, isn't she? She's a training program?
She is. She's the program director.
Isn't that something? That's fantastic. Yeah, well, she's wonderful. She's wrote a very interesting article that's thoughtful, that I don't think I've seen much of, in that how the devices and materials actually get approval. She describes it. Really, things are just compared against historical things that somebody said was okay, that weren't ever tested to see if they were okay in the first place, which I don't think, at least I don't know that I thought of it that carefully, but I don't think a lot of people do. But she did talk a little bit about complication rates. And so there's a couple things I'd like us to talk about in complication rates. One is that even though complications in hernia operations can tend to be low frequency, they're frequently high magnitude. And, or they can be, especially when you start getting into mesh into GI tract and things like that, which is, I'm certainly jaded by the number of people that have been sent to me that have stool leaking through giant chunks of mesh everywhere, and I've had to explant all of it and then rebuild whatever was left. But the other thing is that I'm not sure that everybody knows what their complication rates are in the world of hernia surgery, because so many of the people who have problems either go somewhere else or show up at some time when the people who did the original procedure aren't even around. They've moved on or retired or done whatever they're going to do. So I don't feel like we really know what our complication rates are. I mean, what are your thoughts on that?
Yeah, this is a big challenge in hernia surgery. And what you're getting at really is, and what Ajita outlines, is the need for registries and following devices after implantation in a better way. And I think you're right. Patient goes to somebody else after you've operated. You may never know that occurred. So it's hard for you, even if you are using some mechanism to follow your own data, whether it's through one of the societies or Abdominal Core Health Quality Collaborative, where you enter your own information so you can track it. If they don't come back to you, you won't know that. So to your other point about the complications being so significant, but at lower rates, the key there is that then if we're not tracking and we have these very significant events, we want to know about them, but they're at lower rates. And so we're never capturing how frequently these really occur. But if you talk to any surgeon who's been doing abdominal wall surgery for a long time, you'll hear about the mesh erosions, the fistulas, and so they're all out there. It's a real thing. It's not a one-off. We need to be able to track those back to devices themselves and identify, is this something that we should change? Do we need to notify a manufacturer about something that we've identified as a surgical group? Ajita was part of a very similar finding with his Medtronic. Had a mesh they introduced a 50 by 50 sheet of polyester heavyweight mesh, and they had a very high rate of fracture in the mesh. It was, patients were showing back up with recurrences at a higher frequency than was expected. Surgeons who were using the Abdominal Core Health Quality Collaborative were able to recognize this And Abdominal Core Health Quality Collaborative, in combination with the FDA and Medtronic, recognized that this is something that needs to be recalled, and it currently has a recall on it. And it's not supposed to be used for transverse abdominis release or posterior component separation. So I think that concept is out there about how it can actually be successful, and that's a perfect example of how actually Ajita is involved in something like that.
In my idealized view of medicine, where all of our information flows seamlessly to one another, this would work. There's a bunch of barriers in place there, some of them legal, HIPAA not being the least. When I was in the military, certainly we had a better way of sharing information, but we didn't share information with the VA, for example, at least not readily, because they're two different departments of government. And a lot of the people who show up, with emergent complications, they've had a hernia repair fail, they've got a bowel obstruction, they've got something else going on. They kind of just show up wherever they are. And we've all seen people come in and I don't know in your facility, but it might even be that within a facility, somebody has their procedure done by X. Like bariatrics, a good example. The bariatrics people operate on somebody and they have a complication and they come into an acute care service. And it's like the two people who took care of them don't even work on the same planet, let alone the fact they're in the same building, 3 doors away from one another. And you don't always get information to flow internally. And obviously there are some ways where it's better to happen, but it's a struggle. We're not Switzerland, with a captive population and everybody knows to fill out their forms just so. Those guys got it down. It would seem that if we're really going to track this stuff long term, we need to have some more universal way of following it. And if you're out in some hospital and somebody's visiting you, I've worked in a number of places where the population fluctuates by about 400% seasonally. So you've got a totally different group of people living there X number of months of the year than the opposite season usually. There's no way you're going to know who did what, when, and where. Who came up from Florida for the summer? I don't know how you'd practically do it.
It is a challenge. I think we'll get there. If you look to orthopedics, there are groups that have shown ways that they can work collaboratively and follow device life cycles. And what that looks like for hernia surgery, I think is at its infancy. I think we're behind in that, but I think it's definitely doable.
Well, it's a good point. Like when you look at AICDs and pacemakers, it's easy to find out stuff on them. Patients carry a card with a number. You can usually call 1-800 or get online anytime you want and find out everything you need to know about the device. You can even ask them to give you the last time it was interrogated half the time. So I guess if we can do it with that, there's no reason why we shouldn't be able to do it with some other prosthetic. One of the other things that Ajita talked about a little bit that I found interesting, and maybe it's because I had somewhat of a background in compliance once upon a time, were the conflict interest issues. And I don't think it's necessarily just monetary, but there's certainly some academic conflicts. There's some ego conflicts. There's, some professional, this is the way I've always done it, and this is the way I'm always going to do it, conflicts. What do you think about managing our way out of that situation?
Oh, managing conflicts. You could do a whole issue and series on that alone.
Maybe we will.
Yeah, most certainly. Conflict management when it comes to conflict of interest is imperative when it comes to devices. I think it's right in front of us. I think we can all see how it works. And I think people just have to accept honesty. And I think it's okay to get involved with industry and to promote. I think that's, it's something that we need to engage device companies to better how we're ultimately going to fix a hernia in 50 years from now. But we have to do it through proper conflict management. And who is ultimately responsible for that? Unfortunately, it's the person who's managing their own conflict. It's the surgeon, or it's the organization that they're working for, or the company that they're working with. Is it a requirement? Should it be a governmental requirement that a conflict of interest are shown in some other fashion? It's certainly doable, but I don't know that you can regulate it outside of your own ethical and moral compass. I think that's where it has to begin.
I was in charge of this stuff for about a dozen years when I was in Wisconsin. And what we used to tell people is it's okay to have a conflict of interest. That in and of itself is not a problem. But the two big features are they have to be disclosed and they have to be managed. And while we believed all the people that work for us would do the right thing given the options, we opted not to let them be the sole arbiter of that. when there are conflicts, particularly with publishing, and we don't see it too much in the clinic series because we're more review and less primary article type publishing, but we do want to see that the conflicts are disclosed. I don't know that we spend a lot of time in this series seeing how they're managed, but at least where I've worked, we had third-party management inside, and it was for no other reason. It's very protective for the person who has the alleged conflict or the reported conflict, because you can protect them from a lot of badness should it come down the road later if you can show you went through due process and had that conflict managed. And that was certainly helpful to some people, some things that went legal routes later. It saved their bacon. So a lot of times people complained about the process, but they didn't complain when it stopped some lawful process from moving on later on where they're going to get dragged into a lawsuit. Now they weren't. I mean, most of us surgeons just want to do things our own way all the time, and we don't want our judgment questioned. And I'm right up there with them in my raw id form. But when I get outside that, I think it's a good idea to have our ideas subjected to criticism and constraint. And a big organization like yours is in a position to do it well. A couple of boards I sat on with people, there was Cleveland Clinic and Geisinger and us and Gunderson Lutheran and a handful of other people around. And I think there's an appetite for it, but it is hard on a one-on-one level. You can manage the monetary conflicts. It's when somebody has their ego and their self-worth buried in something they're developing.
It's two things that I would say kind of about your last comment. One is regarding sort of that bias that somebody might have when they're studying, and they, obviously they want inherently what their practice is to be the better outcome. Corey Chris is a surgeon who was doing research at the University of Michigan and actually looked at the robotic data in the system and all the publications, and the number of publications that were positive compared to negative, and its association with whether or not the authors were paid by Intuitive, there was a huge association. So it is out there in the literature, and it's a little bit where I kind of come to the concept of it really has to be within you to say to also recognize that can happen. But again, these are biases, so sometimes you can't recognize it. The second thing, you mentioned the monetary component of it. I actually think that that's one of the harder things that people have to manage, because it can be at times maybe embarrassing for them to recognize how much money they may be making. I mean, I can tell you, I've listened to talks from people when I go to a meeting, and then you end up in a dinner situation and you listen to somebody talk, and then you look up how much they've been paid by that company, and it's in the $200,000 to $300,000 in a year. And tell me, how does that person truly manage their conflict?
That's where you need third-party oversight. And we had people with patents. I mean, Warfarin, the Wisconsin Alumni Research Foundation comes from Warfarin money. And so there's a lot of intellectual property, and it is hard, but that's, I didn't learn any of that stuff in medical school or residency or fellowship, but I learned it as a staff guy when I was in a position of leadership and directorship. And you learn it sitting next to general counsel for years, finding out where the lines are drawn and that you're going to get electrocuted if you touch them. If you sign your form after the Enron debacle, when your signature goes on the bottom, you can't use ignorant as an excuse. You're going to jail anyway. So that's highly motivating, at least in my experience. But I don't think it's going to come down to that for everybody. I've tried my best in every place where I've had a handle on the salary situation to pay all my surgeons a straight salary so that it takes out the conflict of interest about whether they offer somebody an operation or tell them they don't need one. Because you don't get paid nearly as much to tell somebody you'll be fine without an operation as you do to go do something.
That was mentioned in Ajita's article, but it also goes back to the New York Times article. Whether or not our compensation mechanism, RVU based or non-RVU based, is whether what is right and what is wrong. I think that's a whole other debate, but I can tell you that I'm a salaried employee. I don't get paid RVU productivity bonuses or anything. So it's nice in that sense that I can tell somebody they don't need an operation, and it's not going to affect my take home at the end of the day, which is, I think there is something nice to that. And I can't speak. I've never been at a facility where you've gotten paid based on your RVU. There's sort of the eat what you kill, mechanism of compensation. But I can definitely see how people can be influenced, and that doesn't mean you're a bad person. It's just that's the environment. You're trying to put food on your own table and live your own life standards.
My personal experience is that when I've taken people off productivity-based compensation formulas and put them on straight salary-based formulas, none of their productivity went up or down. Whatever their mindset is, they just stick with it. The people who operated a ton kept operating a ton. And the people who didn't operate very much at all for whatever their reasons, they didn't seem to pick up one way or the next. In the absence of a system that's developed, I mean, and the culture of your organization, like a good organization with good M&M and good cohesiveness, and people knowing that their partners are looking out after them and looking in on them, that probably keeps people honest more than anything. Surgeons don't want to stand up, but you get the standalone person who's got nobody looking over their shoulder ever. Those are the people, to me, that I worry more about, these insidious forces taking over their better judgment. And maybe I'm wrong about that. Anyway, the last chapter we have in here is yours. Fantastic chapter about something I think doesn't get anywhere near the amount of recognition that it should, but the management of chronic postoperative inguinal pain. I'll say postop pain in general. We've certainly gone through most of the postop pain discussion revolves around the opioid use, which I don't think is really the point of this. You describe chronic pain as being at least 3 months in duration and at least 3 months after the operation, and where you start the clock may start how soon you get to throw the flag on it's now chronic postoperative pain. But it sounded like you were discussing about a 10 to 15% incidence in this. Do you think that number is on the mark, or do you think maybe it's high and low for the same follow-up reasons we talked about earlier?
So I think that number is about as close to the mark as you're going to get. And I think, it comes from Swedish surgical data where they looked at 23,000 people after inguinal hernia surgeries and surveyed them 1 year afterwards. And they asked them about their pain level within the last week. Were you having any pain as related to the site of your surgery? Were you feeling any pain and discomfort that impacted your ability to concentrate or to do activities, or actually seeking medical attention? And 10 to 15% is 10% of people at least having an impact on their activity, and 15% at least having an impact on their concentration. So I think if you look at that from a perspective of talking to a patient about the potential outcomes after you fix their inguinal hernia, that is how I describe it for everybody. I always tell them the pelvis is a very sensitive area. Doesn't matter if I put mesh on the inside, I put mesh on the outside, or if I fix it with just suture. There's nerves running through that area. There's a lot of muscles that interact with one another. And on average, 10 to 15% of people, if I ask them 1 year after surgery, they're going to tell me that they're still having some recognition that they had a hernia operation that reminds them that on a regular basis. Doesn't mean that they're not doing activity, doesn't mean that they're shutting their life down. But I always tell people, you're going to get hints that you had a hernia operation, that, some little tugging and pulling here and there is totally normal. I think that's where the conversation needs to begin a lot with chronic postoperative pain, is in the preoperative setting, about expectations for the long term.
For the readers listening to us, I strongly urge them to read through your description of the anatomy and the neuroanatomy, because it's incredibly well positioned, and it's usually hard to find a good description. So I think we owe you a debt of gratitude for that. I predate when people would use mesh routinely. Not everybody, some people, but in the early part of my career, the staff guys who were significantly older than I am, some of them were never meshers. And when I took the boards the first time, there'd be a lot of questions asked about various relaxing incisions for hernias that we don't talk about so much anymore. But there was a lot of attention paid to identifying structures and protecting them as you went along. It seems to me in the videoscopic era, similar discussions, just from a very different vantage point. And I still think, do you think there's a big difference between that 10 to 15% number for people with anterior open approaches or posterior videoscopic approaches? It looked like you were leaning that way in the article.
I don't think that there's a tremendous difference in terms of that level of feeling the tugging and pulling and some recognition of discomfort when it comes to 10 to 15%. When it comes to people who are actually seeking medical attention, that 1 to 3% of operations, I think it's equal, but I think that the two present very different challenges in management. And I think, one of the things that skews the data a lot for the open approach is the historical use of plugs, in my opinion.
Yeah, which I've never used, not even once.
So I think if you completely eliminate plugs, in my mind, there's no difference between anterior and posterior. I think plugs have skewed the data tremendously. So it's what I get into, and I think I appreciate the comment about the neuroanatomy, and really what that I think people should take home from that portion of it is that if your best understanding of the neuroanatomy is an open approach or a laparoscopic, that should probably be your go-to. Understanding the anatomy of an inguinal canal, I think, is one of the more difficult in all of surgery. And I don't think that doing MIS approach or an open approach is right or wrong. I think what's right or wrong is making sure that whichever way you do it well, and you take your time and you're meticulous about it and understand the anatomy. That's going to have the best outcome, in my opinion.
The two operations that I always felt were completely mischaracterized was when somebody said that hernia repairs and appendectomies are intern cases. Either of those cases can be the things that will drive you the most crazy, especially in the old days of open hernia repair through small incisions. Laparoscopes has changed the game a little bit. Just in the last few minutes we have, somebody comes to you, they've had 4 months of pain from month 5 to month 9. They've been sent to you because you're the wizard. What's your diagnostic routine to sort out what you think their problem is?
Yeah, so I can tell you that my situation is probably a little bit unique because I established a multidisciplinary chronic groin pain clinic. People who come to that clinic actually get 3 visits. They get one with me, where I do a thorough history examination, including dermatomal mapping, where I'm looking to see, if there's any nerve identification as far as where their pain's related to. They get a dynamic ultrasound. That's my preferred. Now, I will say that if you don't have that at your institution, or you haven't established a protocol with your radiologist, getting an MRI is equally as good.
Now, do you do the ultrasound yourself, or do you have your radiologist?
Nope, I have. I work with our musculoskeletal radiologists, and they do it. I've actually met with the radiology techs who do the ultrasound themselves, and have given them presentations on chronic groin pain, what we find in the operating room, the nerves, with what I see in the operating correlate to what they see when they're ultrasounding, so that everybody's kind of on the same page. And then the last person that they see is actually a pain psychologist or behavioral pain medicine person, because the one thing I've learned dealing with a lot of patients with chronic groin pain after inguinal hernia surgery is that, pain is multifactorial. It's not as simple as you had an operation or didn't have an operation. There's your own psychological history, your history growing up as a child. Unfortunately, we've identified that, rates of chronic groin pain, the people who come to my clinic have rates up as high as 25% of them had some form of sexual, physical, or emotional abuse as a child. Part of the reason why I tell people about the physiologic or the psychological component is that as surgeons, we have to recognize that it's totally okay to say that I caused chronic pain in a patient when I did an inguinal hernia repair. It's going to happen. I've done it. I'm sure you've done it. People listening have all done it. The key is not to ignore it, and then to get to the next steps of trying to treat them. So if they are coming to me, again, I do ultrasound, behavioral medicine, myself with a thorough history, and physical.
Too few people bring in like cognitive behavioral therapy and sort of the non-operative side of the equation. I find a lot of people I know, they'll do some injections, they'll call the pain guys. If that doesn't work, they'll start talking to people about neurectomies of some form. I'm not sure. I think that's skipping some steps. I think your approach is better. What percentage of people do you think you have to resort to operative management for chronic pain?
Surgical management is probably about 50% that I end up removing mesh or doing neurectomy on. It's amazing how many people just need reassurance. A lot of discussion about mesh and the concern about meshes that we hear, litigation ads and whatnot. And that's impacted people's psychological component to having a foreign material in them. And their assumption is if there's pain, something bad must be going on. So we always talk about the difference between hurt and harm, which is just because something hurts you doesn't necessarily mean that there's any harm going on behind the scene. And that if your level of pain is a 2 and you can do everything that you want, I always tell those people there's no role for surgery, cutting nerves, or taking your mesh out, because I can make things worse by doing so. So, I mean, we do typically reserve surgery for people who are really reaching the point of debilitation, whether, how it's impacting their quality of life or they're not able to work. If it's really low-level pain, I talk them off the ledge of any sort of intervention surgically.
And I think the thing is it's amazing how many people, if you just sit down with them, listen to their concerns, tell them they're not making it up or whatever they've been told by somebody else, and help them to understand the processes you just described, that goes an awful long way with a whole lot of patients. A lot of people don't want to invest that time, and I never understood it because it's way easier than all the other stuff we would do if we didn't invest the time. Well, anyway, I think we're probably wrapping up on time here. I want to, again, thank you and all your colleagues who I admire tremendously for putting together a fantastic issue. This will hit general surgeons where they live very much. There'll be a lot of interest in this topic, and we're deeply in your debt. Thank you, David.
Well, thank you for having me.
Thank you for joining us for this Surgical Clinics podcast devoted to abdominal core health. The 4 articles discussed, as well as 12 others, are in the October 2023 issue, Volume 103, Number 5. This series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, and Amazon Music. Thanks for listening.